So in this session, we're going to be mainly covering thyroid disorders, adrenal disorders, and balances of sodium and calcium. So I prepared a few single best answer questions just to have a read through, and then we'll talk over the answer. Okay, so the first one is, as a 54-year-old woman presents the GP feeling tired despite very minimal activity. She's feeling quite cold as well and constipated. And on her neck, you notice a smooth, uniformly enlarged and non-tender goiter. So just give people a few moments to think about which of these they think is most likely the reason for her presentation. So based on the features presented here, the most likely diagnosis is Hashimoto's. So the reason for this is that you know that this patient typically has hypothyroid features. So she's feeling cold, constipated, and fatigued. So that rules out Graves' disease as a cause. The fact that she has a goiter implies that it's primarily a thyroid issue rather than a pituitary issue, making benign pituitary tumor unlikely. And that leaves us then with the remaining three. Derquavane's thyroiditis has an acute phase where you're hyperthyroid, and then an underactive phase where you're hypothyroid. But given that this patient hasn't complained of recent illness and the goiter is non-tender, that makes Derquavane's thyroiditis less likely as well. And lastly, that leaves us then with atrophic and Hashimoto's. And as in the name, atrophic hypothyroiditis basically means that the thyroid gland is atrophied due to inflammation, so you wouldn't have a goiter. So that leaves us with Hashimoto's thyroiditis being the most likely cause for this patient's hypothyroidism. So just generally talking about hypothyroidism, you can classify it as primary or secondary. So primary hypothyroidism is due to an issue with the thyroid gland. So that means that when you do a blood test, you'd find low serum T4 and T3. And due to negative feedback or reduced negative feedback, you'd see an increase in TSH. So reasons for this can be autoimmune. So we talked about Hashimoto's and primary atrophic thyroiditis already. The main difference being whether there's a goiter or not. More rarely is renal thyroiditis, which is where there's fibrotic inflammation of the thyroid gland. And lastly, postpartum thyroiditis. So women who are either near term or just given birth can also develop hypothyroidism in the underactive phase of that disease. Obviously, we have to think about thyroid issues that we can cause as clinicians. So whether we've undergone a thyroidectomy, well, whether we've irradiated the patient's thyroid gland. So this can be external neck radiation or radioactive iodine therapy that is used in hyperthyroidism. It can be that the patient's had a recent thyroidectomy. More commonly worldwide is actually defects in hormone synthesis, so iodine deficiency. Drug-induced hypothyroidism, so drugs that are typically quite iodine rich, like amiodarone, can cause hypothyroidism. Antithyroid drugs can shut down your thyroid gland. Lithium as well is well known to cause hypothyroidism. And then inborn errors where there's dyshormonogenesis. Infiltrations, so tumors of the thyroid gland, if they infiltrate healthy tissue, can cause a patient to become hypothyroid. And I've already talked about thyroiditis or viral thyroiditis. In the post-acute phase, you can have a hypothyroid phase while the patient's thyroid gland is recovering. And lastly, I touched on about this with the defects in hormone synthesis, so congenital reasons, so patients are lacking a thyroid gland, so agenesis, for example. Next, there's secondary hypothyroidism. So this is with an issue higher up, so typically in the hypothalamus or the pituitary. So you have reduced TSH stimulating the thyroid gland, and therefore you have reduced T4 and T3 production. So what can cause this? So this can be at the level of the hypothalamus, the level of the pituitary stalk, or at the level of the pituitary gland itself. And so hypothalamus, thinking about your surgical sieves, so tumors, infections, ischemia, inflammation. Congenital causes quite rare, so diseases like Kalman syndrome can manifest as hypothyroidism. Diseases of the pituitary stalk, so compression of the pituitary stalk by trauma, by a mass lesion like a tumor, or if it's damaged during neurosurgery, and lesions of the pituitary gland itself, so ischemia of the pituitary, surgery, trauma, tumors, inflammation of the pituitary gland, infiltration, diseases such as amyloid, and sarcoidosis as well. So someone just what's Kalman syndrome. So Kalman's syndrome is a congenital disease where there is failure of the actual maturation of the cells in the hypothalamus. Usually this is actually more commonly presenting as patients who fail to go through puberty or infertile, but in rare cases it can manifest as hypothyroidism as well. So how do patients with hypothyroidism present? So you can see in this picture quite clearly, you can characterize these symptoms really based on body system, but an easy way to remember how a patient hypothyroidism presents is that everything in the body will slow down. So thinking about speech slowing down, so their speech often becomes quite deep. Thinking about heart, so they often become bradycardic. Thinking about the GI tract, they'll become constipated. Thinking about the brain function, they'll become more fatigued, they may become depressed, they may have a degree of cognitive impairment and confusion. Their rate of metabolism slows down, so they're often gaining weight, and they're often feeling very cold despite it being warm outside. In women in particular, you should always ask about menstrual history in a patient with suspected thyroid issues, because in hypothyroid patients, they're often complaining of heavy periods. In terms of the signs, goiter, as I said before, is dependent on what the underlying cause of the hypothyroidism is. You'll find that these patients often have slow relaxing reflexes. They may have a degree of peripheral neuropathy and edema as well. And in extreme states, they can develop pleural effusions and also congestive cardiac failure as well. So how do you investigate hypothyroidism? So already alluded to this earlier. So first thing you do is your thyroid function tests, and you would expect there to be a low T4 or T3, and TSH will be either raised or decreased depending on whether it's primary or secondary cause. To investigate further, you can do a full blood count. Patients with hypothyroidism are often anemic, which won't be helping with their tiredness. And this is usually a macrocytic anemia. And if you're specifically thinking about Hashimoto's thyroiditis, they usually have positive TPO antibodies. So these are antibodies against thyroperoxidase enzymes, which are involved in thyroid hormone synthesis. So how do you manage someone with hypothyroidism? You replace what's missing. So you start usually with 50 micrograms of levothyroxine. You may start with a lower dose depending on the patient. So for example, if they're elderly or they have a history of cardiac disease, and then you'll titrate to manage the symptoms as appropriate. So you can get an extreme state of hypothyroidism. So this is known as myxedemal coma. So there's often usually a preceding trigger to this. So the patient could develop an infection, recent trauma, or a recent heart attack. And the presentation is basically the extreme of hypothyroidism. So they're extremely hypothermic, hyperreflexic, hypoglycemic, very slow heart rate, and they can become comatose. So how do you manage them? Give them oxygen. You want to treat the underlying cause, and you also want to supplement their thyroid gland. So usually this would be for giving IV levothyronine, which is patients with hyperthyroidism is T4. So you start with T3 and then you switch to oral T4 when possible. They are prone to hypoglycemia, so you're correcting their blood sugars, and you also want to give them IV hydrocortisone. You should actually give this before you give any thyroid hormone, because if the patient's actually got secondary hypothyroidism due to hypopituitarism, then they may actually have a degree of adrenal insufficiency, which may be uncorrected. And then symptomatically treat. So if they're cold, you may need to actively warm them, and antibiotics for any chronic events. So they may not be compliant with their thyroid medication. They may, and they're not adequately being treated. If they have one of these triggering events, this can then cause them to become extremely hypothyroid. So moving on to this next question for people to have a look at. Okay, sorry. So in terms, so what I was saying before about, so someone just asked about the mixed dermal coma. So it can be an acute deterioration thyroid state, but in most cases, it's usually a chronic deterioration in the patient who maybe hasn't had their thyroid gland well controlled, and then they have one of these triggering events which their body cannot cope with. So when you think about it, states of infection, states of trauma, following an MI, your body really needs to be metabolically active to heal, and it's not able to do that if the patient's severely hypothyroid. So just moving on to the next question. So 34-year-old female, again, comes to a GP saying that her periods started becoming irregular. She's always feeling hot and feels her heart racing. And when you examine her, you find a smooth enlarged goiter that's palpable. Your blood test shows she's got a TSH receptor antibody positive blood. So this is more for questions focused on treatment. So just have a moment to think about which of these treatments you think this patient should have. So this patient clearly has features of hyperthyroidism, and the fact that she has TSH receptor antibodies and the smooth enlarged goiter point to this being Graves' disease as the most likely diagnosis. So you want to treat her for hyperthyroidism, specifically Graves' disease. But the key here is the question is asking for symptomatic treatment. So propranolol would be the most appropriate answer in this case, because propranolol would immediately manage her symptoms of particularly the tachycardia. While you may think about carbimazole, propylthiouracil being appropriate options for her, don't forget that these do take some time to act and they wouldn't resolve the symptoms straight away. So usually you'd give her some propranolol, tie her over until the antithyroid drugs take effect. Thyroidectomy can be considered in patients with Graves' disease, but this is usually considered after a trial of antithyroid drugs. Radioiodine treatment usually isn't given in Graves' disease. This is because it can actually worsen Thyroid Eye Disease, so it's usually avoided. So, moving on to hyperthyroidism, again, like most endocrine diseases, can be categorized as primary or secondary. Primary being a disease of the actual thyroid gland, making too much T4 and T3. By negative feedback, this then suppresses your TSH. So what can cause this? The most common cause is Graves' disease. As I said before, it's a TSH receptor antibody-mediated disease, causes you to get a smooth enlarged goiter. You can get hyperfunctioning multinodular goiters or hyperfunctioning adenomas. And lastly, like with hypothyroidism, thyroiditis can cause hypothyroidism in the acute phase. So this is where there's active inflammation in the gland, and the thyroid hormone that's stored in the gland is being released. Drugs can also cause your thyroid gland to increase its hormone production. So there's two different types here. Type 1 is where you get to goiter, and this is usually because there's a drug, the amiodarone is usually iodine rich, and this drives hormone synthesis through the excess iodine that you're supplying the gland. And because you're producing more hormone, the gland gets bigger as a result. Type 2 is destructive thyroiditis. So this is where the amiodarone actually causes the thyroid gland to become inflamed and atrophy. So you get no goiter. And the reason that you get hyperthyroidism in these patients is similar to how you get it in viral thyroiditis. The glands becoming inflamed and any stored thyroid hormones being released into the body circulation. Secondary hyperthyroidism. This is again due to problems in hypothalamus or the pituitary. Overall, these are more rare causes of overall, these are more rare causes of hyperthyroidism, but of those, usually pituitary adenoma would be the culprit. And this is because it increases TSH production and therefore increases T4 and T3 production. I think someone's just asked a question about amiodarone causing hypothyroidism. So the reason amiodarone can cause hypothyroidism and hyperthyroidism is both because of its rich iodine. So if you think back to your early preclinical years, you may be familiar with Wolff-Chaikoff effect, where if you overload the thyroid gland with iodine, it can actually cause the thyroid gland to shut down as a way of counter-regulating against that. And that's why amiodarone can cause hypothyroidism. But on the other hand, with the excess iodine, it may drive thyroid hormone production. It's very difficult to predict in which patients will become hypothyroidism, which patients will become hypothyroid, and which ones become hyperthyroid. So it's important to watch out for both of these features when you're starting someone on a drug like amiodarone, as they could go either way. And just briefly, there are other causes of hyperthyroidism, and this is because you can be introducing thyroid hormone externally from that which is produced by your thyroid gland. So these are things like factitious thyrotoxicosis, so patients being a bit naughty and taking too much thyroid hormone, or taking thyroid levothyroxine which isn't theirs. Another more rare cause is a disease called stroma ovari, and this is where you get an ovarian teratoma, which actually produces ectopic thyroid hormone, which again is very rare and not something that you should really be worrying about. How does hypothyroidism present? So the exact opposite of hypothyroidism, everything in your body speeds up. So metabolism speeds up, causing you to lose weight, and you become very intolerant to heat. Your cardiovascular system speeds up, so you become tachycardic, and you often become anxious with a tremor. Thinking about your brain activity, patients often become quite agitated, and they can actually become psychotic, secondary to hypothyroidism. So it's often a differential that you consider in someone who presents with acute psychosis. They're often excessively sweating. If you think about their GI system, they may have diarrhea. Like in the scenario I gave you, going back to periods, they often become oligomenorrheic, or they may become amenorrheic. And because you've got increased rates of metabolism, their bone turnover increases, so they're more prone to osteoporosis and fragility fractures. Signs of hypothyroidism, they're often peripherally very warm, well diffused. They often have a degree of proximal myopathy. Again, goiters will depend on the underlying cause, and they're often in sympathetic overdrive. So they're tachycardic, palpitations, they may have a degree of lid lag and the tremor. And because of their fast rate of the fast heart rate, they may actually go into AF as well, something to think about. So thinking about specific features of thyroid hyperthyroidism patients, in Graves' disease, you obviously have the eyes and the pretibial myxedemia. So as the main ones you often think about. So Thyroid Eye Disease, you have exophthalmos. So you often see these patients often have eyes protruding out. Pretibial myxedemia, so they have non-pitting swelling of their shins. Thyroid acropatchy, that is basically just clubbing of the nails. They'll have ophthalmoplegia along with their Graves' eye disease. They may have difficulty with eye movements and may complain of diplopia. And they will have a smooth enlarged goiter, as I said earlier. Viral thyroiditis is something that I've talked about before. And as I said, there are different phases of the disease. So you have the acute phase where the patient is hyperthyroid because the virus has inflamed the gland and caused stored thyroid hormone to be released. So they'll often have a painful goiter because of the inflammation. They may have a degree of dysphagia because of the pain, and they'll often be pyrexia with a raised ESR. Once the acute inflammation is resolved, they'll become initially euthyroid, and then they may become hypothyroid. And this hypothyroid phase may last for weeks or months, and their thyroid function may actually never recover. But in most cases, they will regain a degree of that. But how long it will take varies from patient to patient. So how do you investigate hyperthyroidism? Again, broadly similar to hypothyroid. So you get your thyroid function tests, and again, your TSH will tell you whether you're thinking this is a primary disease or secondary disease. If it's thyroiditis, look at your inflammatory markers as they may be raised. Thyroid autoantibodies can give you a clue. So as I said, anti-TSH receptor positive in Graves' disease. If you're still unclear about what the cause of the disease is, you can get nuclear scintigraphy and look at the uptake of an iodine-rich marker into the thyroid gland. So in Graves' disease, there's uniform uptake. In nodular disease, you often see that it's only the nodules which are hot. And if it's thyroiditis, you'll see that it's actually reduced uptake globally because the thyroid gland isn't working. And if the patient does have a nodule, it's often good to get an ultrasound of the thyroid to have a look at the underlying structures of that nodule, and a biopsy may be indicated depending on what is found. So are there any particular viruses that may cause viral thyroiditis? So viruses, so usually the most common viruses are the ones that are mostly associated with your common coughs and colds. It's nothing unusual in terms of viral thyroiditis. Usually you wouldn't bother actually investigating what virus caused it in most cases. So thyroiditis, for the purpose of this talk, when I say thyroiditis, I'm usually referring to viral or liquid veins. Obviously there is postpartum thyroiditis, which is a different subset for patients post-pregnancy. So how do you treat a patient with hyperthyroidism? So as I said before, initially you want to symptomatically control them. So this can be done through things like a beta blocker, obviously taking into account that they don't have any contraindications to that. Then you'd be thinking about starting an antithyroid drug. So there's different options available. So carbimazole is one, propylthiouracil is another. So there's two different strategies that are used. One is titration. So you start the drug and then you titrate it up or down based on the TSH level to maintain it in the normal range. Another strategy which is used is a block and replace mechanism. So you give a higher dose of your antithyroid drug, completely shut off the thyroid gland, and then you replace the thyroid hormone with levothyroxine at the same time. With antithyroid drugs, the main side effect and ones that often comes up in exams is agranulocytosis. So you often counsel patients that if they start feeling unwell, if they have a sore throat, then they need to see medical attention or blood tests to make sure that they've not got agranulocytosis. So drug treatment is often used the most popular option in Graves' disease as first-line treatment. Usually you start this and continue it for 12 to 18 months before reviewing. Radioiodine is another line of treatment, usually used in treatment of toxic multinodular goiters, or if there's been a relapse or resistance to antithyroid drugs. As I said before, avoid using in thyroid eye disease as it can make the disease worse. And you have to be careful as it can actually precipitate a thyroid storm because, as I said before, because you're giving a source of iodine, it may stimulate the thyroid gland to actually produce more thyroid hormone before actually causing the thyroid gland to be shut off. And lastly, another option and an alternative is thyroidectomy. And obviously, if you're getting rid of the thyroid gland, then you can expect patients from hypothyroid and hypoparathyroid. And just thinking about locally, the recurrent laryngeal nerve runs very close to the thyroid gland. So you have to warn the patient that this could be damaged in a potential operation. Thyroid eye disease is another name for Graves' orbitopathy or Graves' ophthalmoplegia. So basically, it's where the TSH receptor autoantibodies cause inflammation at the back of the eye, usually by binding to different structures and soft tissues, and this causes ophthalmoplegia. But that's usually a bit more specialist. And usually when you detect it, it's actually usually managed by ophthalmologists. And you want to avoid radioiodine in the thyroid eye disease because it can worsen and accelerate the progression of thyroid eye disease. So just on specific management of underlying causes. So viral thyroiditis, usually self-limiting, so you don't usually need to treat them. You can give them an NSAID just for pain relief. You can give them a beta blocker to symptomatically treat them in the hyperthyroid phase. If it's really severe and they've got lots of inflammation, you can give them a steroid, but this is usually something that will be decided by a senior. And if they're in the prolonged hypothyroid phase, you can consider levothyroxine. And as I said before, with the amiodarone causing hyperthyroidism, the way you treat it depends on which type it is. So type 1 disease, where you've got a goiter, you give them carbimazole or potassium perchlorate. Both these are designed to shut off the thyroid gland. If it's type 2 and they've got active inflammation in the thyroid gland causing it to become atrophic, you'd want to give them steroids. And like with hypothyroidism, where you have mixed edema coma, with hyperthyroidism, you can get thyroid storm. So again, usually these patients have a triggering event, and this is usually a more acute event. So they may have an infection, a recent MI or trauma, or they may have had a recent thyroid operation or radioiodine administered, and they're often extremely tachycardic or an AF, agitated, confused, and they can end up in a coma. So how do you treat this? You need to keep them well hydrated, symptomatically treat with a beta blocker, give them antithyroid drugs to shut off their thyroid gland, and give them hydrocortisone. The reason for that is that hydrocortisone actually slows down the conversion of the less active T4 to the more active T3 within the body's tissues. So it can have an effect in slowing down the action of thyroid hormone. And because they're often, they can become pyrexial, you need to make sure that they're cooled with tepid sponging or paracetamol as needed. So just a third scenario, I've already highlighted the answer already, so I'll just talk through it straight. So a 41-year-old woman referred to the endocrine clinic by her GP, appearing overweight, complaining of weakness in her arms when she's lifting objects. And when you examine her, there's bruising along her arms and visible stretch marks on her abdomen. On blood test, you find elevated early morning cortisol. So what's the most appropriate initial investigation? So usually nowadays, what we tend to do in patients with suspected Cushing's disease based off early morning cortisol is we give them an overnight dexamethasone suppression test as the first line investigation. And this is mainly to confirm that they have Cushing's disease. And you can tell from the features here that we're thinking along those lines. So she has some of the classical features. So it's overweight, proximal myopathy, stretch marks, and easy bruising. Random plasma cortisol is not useful in the diagnosis of Cushing's because if you remember back to your preclinical years, cortisol levels have a diurnal rhythm, so they change throughout the day. A 48-hour dexamethasone suppression test is usually done following an overnight suppression test if further confirmation is required. A pituitary MRI can be done if you suspect that it's Cushing's disease, so it's caused by pituitary tumor. So that would be a test that's done later down the line. And inferior pituitary sinus sampling, this is again to determine if there's a pituitary tumor, because you'll be looking for ACTH being produced and secreted in the vascular, the venous circulation around the pituitary gland. Again, this should not be an initial test you'd be doing. So sorry, I should have clarified here. So 48-hour dexamethasone suppression test is a low dose dexamethasone suppression test. Usually high-dose dexamethasone suppression tests are rarely done nowadays, but I'll come on to that a bit later on. So Cushing's syndrome. So Cushing's syndrome can be classified into ACTH dependent disease or ACTH independent disease. Okay. So ACTH disease can be from the pituitary gland itself producing ACTH, so that would be Cushing's disease. And this is the most common cause, so over 50% of cases are due to pituitary tumors. It can be due to an ectopic source of ACTH, so small cell lung carcinomas can cause ectopic ACTH secretion, and these would both increase ACTH and therefore increase your cortisol production by your adrenal gland. ACTH independent causes of Cushing's disease are due to the adrenal cortex producing cortisol independently of ACTH control. So this can be due to an adrenal adenoma, an adrenal carcinoma, or bilateral adrenal hyperplasia. And finally, an important thing to think about is the patient actually on steroid treatment? So are we artificially or iatrogenically giving them excess cortisol, and this is causing them to have symptoms? And this obviously will have negative feedback and cause ACTH secretion to be reduced. So how does Cushing's syndrome present? So I've got a picture here of a gentleman with Cushing's, and you can quite clearly see some of the features. So he's got this very nice centripetal obesity, and this, as you can see, this moon face, so very round face, obesity mainly around the center. You can see he's got striae, so stretch marks on his abdomen as well. You can classify the symptoms as constitutional symptoms, so proximal myopathy, weight gain, tiredness, recurrent infections, diabetes, or osteoporosis. Mood disturbances, so patients can become depressed or become psychotic, and they're often very fatigued and lethargic. And Cushing's syndrome can have an impact on gonad function as well. So in women, they're oligoamenorrheic, and they can become hirsute, and in men, they can become impotent and have erectile dysfunction. And when you're examining these patients, it's worthwhile looking at their blood pressures. They may become hypertensive. They'll often have quite thin skin or bruise easily. They may have acne. And in Cushing's disease or ectopic ACTH, so not really ectopic ACTH production, but in Cushing's disease, because you've got excess ACTH being produced, again, thinking back to your preclinical years, this ACTH ACTH is transcribed from the POMC gene, and part of this is when this is processed, it also produces beta MSH, which stimulates your melanocytes in your skin and causes your skin to become more pigmented in certain cases where there's excess ACTH production. Okay, so someone's asked what's the main difference in Cushing's syndrome and Cushing's disease. All that Cushing's disease means is that the cause of the Cushing's is because of pituitary tumor. So if it says Cushing's disease, that means there's a pituitary tumor that's causing it. Any other cause will be classified as Cushing's syndrome. Okay. So how do we investigate Cushing's? So often we're monitoring their BMs. These patients are prone to becoming type 2 diabetic, and they're often insulin resistant. They often have raised blood glucose levels. If you're screening for Cushing's, then you can do an 8 AM cortisol. This is usually a screening test. This is not a confirmation of Cushing's, and you're looking for this to be elevated. And someone's asked about this earlier, so I'll talk about this now. So the first line tests you do, there are different alternatives. So you can either do a overnight dexamethasone suppression test. So this is where you give someone a dose of dexamethasone, usually at midnight, and then you'd get them in the next day in the morning and measure their cortisol levels. This is the preferred way. Raised 24-hour urinary cortisol is another way of testing for it, but as you can imagine, collecting urine for 24 hours from someone is very cumbersome, so it's not usually done that often anymore. Second line tests. So these are used where the first line tests are indeterminate, really. So 48-hour dexamethasone suppression tests, while they used to be quite mainstream, they are sometimes still used, but they're not used as commonly. They'd usually be instigated once a senior has reviewed them as a confirmatory test. Bin-like cortisols again can be used as a confirmatory test, and the second line test where there's uncertainty, but again not commonly used. So once you've found that the patient has Cushing's, you then need to decide where it is. The first thing you want to do is measure the patient's plasma ACTH, see if that's raised or reduced. And as I talked about the causes before, that will determine where you're looking for. So if you think the patient has an adrenal source, you can then get a CT of the adrenals, see if they have a tumor clearly there. And if you think it's a pituitary source, you can get an MRI of the pituitary gland. Further on, if you've done a CT of the adrenals and they've got bilateral adrenal hyperplasia, for example, or no identifiable tumor, you can do adrenal vein sampling. And this will allow you to localize where most of the cortisol production is coming from and see if it's unilateral or bilateral Cushing, cause for the Cushing's. And going back to the pituitary gland, if you want to confirm that the MRI that the pituitary gland is the reason for it, because don't forget, the majority of pituitary tumors are actually benign and they may not be doing anything. So you'd often get inferior pituitary sinus sampling to see that the ACTH that is produced in excess is actually coming from the pituitary gland. How do you manage Cushing's? So if it's iatrogenic, so you're giving the patients too much steroid, then obviously you need to have a chat with whoever's prescribed the steroid or with your seniors and decide, do they still need the steroid treatment or can it be tapered down? If it's Cushing disease, so it's a pituitary adenoma, then it can be selectively removed through transvenoidal surgery. So this will be done in discussion with neurosurgeons. If you are unable to resect the tumor, or it recurs post-op, then what you can do is you can either give them long-term drugs that suppress the adrenal glands, so like metyrapone, or you can give them a bilateral adrenalectomy. Again, you'd have to then artificially replace their steroid hormone. long term, as they would effectively be adrenal insufficient. If the patient has an adrenal tumor, so adenoma or carcinoma, you can do an adrenalectomy that will often cure an adenoma, but not usually a carcinoma. So if they have a carcinoma, you'll need usually long-term radiotherapy to the gland, and you may need to start some adrenolithic drugs like mitoprolol, which are extremely active against carcinomas. And if it's an ectopic ACTH secretion, then treat the underlying cause. So surgery for an underlying tumor if it's there. If you can't resect the tumor, then you may need to start drugs like metyrapone or ketoconazole, which inhibit the enzymes involved in cortisol production. And these can be done either pre-op, or they can be done while you're waiting for the effects of radiation therapy if you're using that as well. So next question, 35-year-old females come for a routine checkup. Blood pressure is found to be high at 160 at 120. You get ambulatory blood pressure monitoring for her, and you diagnose with hypertension. Do some blood tests and see that the patient's actually hypokalemic as well. Decide to investigate further and find that she's got a raised aldosterone and low renin levels, and CT abdomen shows a tumor of her left adrenal. So thinking about what the most appropriate initial management is here. So this patient has Con syndrome. So they have primary hyperaldosteronism, so they have a raised aldosterone, and this has suppressed their renin levels. And you can say this is Cons because this is a unilateral tumor from the left adrenal only. And it's causing it to become hypertensive and hypokalemic. So how do you treat Con syndrome is basically what this question is asking. So initially, you need to control the symptoms. So yes, adrenalectomy would be the ultimate treatment for this patient to remove the tumor, but you need to control their blood pressure in the short term. So this is done through spironolactone, which is a mineralocorticoid antagonist. So it will directly antagonize the active aldosterone. Okay. The other drugs would not be used in Con syndrome. So primary hyperaldosteronism. So here we have a diagram, basically what's going on. So you have a excess production of aldosterone from your adrenal cortex. This acts on your kidneys, causes your sodium water to be retained and causes you to lose potassium. Retaining sodium and water, this causes increased blood volume, increased cardiac output, and increased blood pressure. And increased blood pressure will have a negative feedback effect on your renin levels and cause that to be suppressed. So different things that can cause this. The most common cause is actually bilateral adrenal hyperplasia. So both adrenals are responsible for the excess aldosterone. About 1/3 of cases, it's an adrenal adenoma, so a distinct benign tumor of one adrenal gland. And this is what is called Con syndrome. It can be due to an adrenal carcinoma. And lastly, a rare cause is glucocorticoid remediable aldosteronism. This basically means that due to genetic abnormality, your aldosterone production is now under the control of ACTH. So that's why it's glucocorticoid remediable, because if you give them steroids, it will suppress their ACTH and then suppress their aldosterone secretion. Again, that's a very rare condition and you're not expected to know much about that. So how did these patients present? So usually they'll actually be asymptomatic. Usually it'll be because they have a high blood pressure and it's resistant to lots of hypertensives, and they're usually quite young when they get this hypertension. If they are symptomatic, it's usually because of the hypokalemia. So excessive thirst, polyuria, muscle weakness, muscle cramps and spasms, paresthesia, and headaches. So your typical features of hypokalemia. How do you investigate hyperaldosteronism? Firstly, can do some routine bloods. You'll find that potassium is low. They may have a normal sodium, they may have a raised sodium, and they often have a degree of metabolic alkalosis. Then if you suspect it, you want to get plasma renin aldosterone levels and together, and it's important you do this after 2 hours in a sitting position. This is because aldosterone secretion is dependent on posture. So these patients will have a raised aldosterone and a low renin. You then want to do a CT abdomen to see if it's bilateral adrenal hyperplasia or there's a adrenal tumor. And if you are unsure, then you can do adrenal vein sampling like you did with Cushing's to see where the aldosterone is coming from. So how do you manage these patients? So as I said, for cons, adrenalectomy is the gold standard, but to control their blood pressure, usually give them spironolactone for about 4 weeks before they have the operation. If it's bilateral adrenal hyperplasia, then usually you'd want to treat them medically, so things like spironolactone or eplerenone, which are mineralocorticoid antagonists, or amiloride, which also acts to inhibit the action of mineralocorticoids, but these are through acting on sodium channels rather than acting on the mineralocorticoid receptors. As I said, with glucocorticoid remediable aldosteronism, giving them steroids to suppress aldosterone secretion. And if they have adrenal carcinoma, it's the same as treating for adrenal carcinoma in surgery if you can, and then post-operative adrenolithic therapy with drugs like mitotane. So another question. So a 28-year-old gentleman presents to GP with dizziness, feeling lightheadedness, frequent episodes of this when he stands. He's lost 4 kilograms over the past 3 months, but thinks this is because he's eating more healthy. On examination, you find that he's got a postural drop in his blood pressure, and you see on his hands, his palmar crease is actually darker than the rest of his hands. So this patient has typical features of adrenal insufficiency. And I'll talk a bit more about these later on. So how do you investigate adrenal insufficiency? So the first line investigation is a short-acting test. So you want to give them some synthetic ACTH to see that they don't have an increase in their cortisol following this. Okay. The rest of the tests would not be confirmations of the diagnosis. So, adrenal insufficiency. So again, adrenal insufficiency can be primary or secondary. So primary adrenal insufficiency is what's called Addison's disease. This is where your adrenal glands are not working. Most common cause in the UK is autoimmune. It's an autoimmune response to the adrenal gland. TB is the most common cause worldwide. Other reasons are metastasis of a tumor to adrenal gland, a lymphoma which has infiltrated the adrenal gland, infections like HIV, hemorrhaging into the adrenal gland, or infiltration of the gland, so sarcoidosis, amyloidosis, or iron overload, like hemochromatosis. So obviously you get reduced cortisol secretion, reduced negative feedback, so your ACTH will increase. Secondary adrenal insufficiency is due to a problem with the pituitary gland. So this can happen if you've abruptly withdrawn someone's steroid treatment, so their pituitary gland hasn't had a chance to respond and increase the ACTH because it's been chronically suppressed, or in a patient who's has hyperpituitarism, so they're naturally not producing ACTH, and this will cause their cortisol levels to decrease. So how these patients present. So again, thinking about symptoms, you can classify them to constitutional symptoms. So they'll be tired, losing weight, muscle pains, joint pains, quite weak and feeling dizzy. They may have a degree of psychiatric presentations of depression or psychosis, and they will have a degree of GI disturbance. So you often find that they often present with abdominal pain, diarrhea, constipation, and vomiting. The signs that you often see are postural hypotension. They may have signs of other autoimmune diseases like vitiligo, and they have this hyperpigmentation. Again, this is like I was saying before, because the pituitary gland is producing excess ACTH in Addison's disease. As I said, the gene that produces ACTH is also responsible for producing beta MSH, which will stimulate pigment production in your melanocytes. So how do you investigate adrenal insufficiency? Again, start off with your routine bloods. They often have a low sodium and a high potassium because of the low mineralocorticoid production. They'll have low glucose because of the low cortisol production. They may be uremic if they have a degree of dehydration. They often have a high calcium. They may have eosinophilia, and they may be anemic. You do a Schultz and Endocrine test to confirm the diagnosis. You'll find that the ACTH in Addison's is high when you measure it, and it's low in other causes. If you think this is Addison's disease, you can do a screen for adrenal autoantibodies to see if there's an autoimmune element, and it's often positive 80% of autoimmune disease patients with adrenal insufficiency. You can do plasmapheresis aldosterone to assess the patient's mineralocorticoid status. You can do chest x-ray and adrenal x-ray. This is because, again, going back to what I was saying before, most common cause worldwide of adrenal insufficiency is actually TB. So it's good to have a look for any evidence of TB on these x-rays. And you can do an adrenal CT if you want to investigate further. So how do you manage adrenal insufficiency? So in the non-acute state, you can, it will be with steroid replacement, so hydrocortisone, usually 3 times a day. They with a higher dose in the morning to compensate for that peak that you get in the mornings with your diurnal variation in steroid levels. You may need to give the patient fludrocortisone, which is your mineralocorticoid agonist, if you find that they're getting postural hypotension or they're having deranged electrolytes. You need to make sure that they have an extra dose of hydrocortisone before they do any strenuous activity, and they'll need to double their dose of hydrocortisone for at least a week if they have an illness or any surgery or trauma. And if they become unwell and they're unable to take medication orally, it's important that they seek medical attention and that they switch to IV or IM hydrocortisone so that they're still getting their steroid. Addison crisis is the extreme state. Again, usually there's a precipitating event, so infection, trauma, surgery, or missing their steroids. And they'll often present with shock, profound hypotension, low GCS, and hypoglycemia. So managing them is an A to E approach. Resuscitate them with fluids, give them IV hydrocortisone and broad-spectrum antibiotics to cover for any infection which may be triggering the Addisonian crisis. You want to aim to change their oral steroids after 72 hours, correct any decrease in glucose with IV glucose if needed, and culture the patient to identify as any source of infection. Next question. So 45-year-old woman referred to ambulatory care unit by a GP, mentioning that around 4 times a week she experiences panic attacks when she feels her heart racing, intense headache, and excessive sweating. But these episodes soon subside. Urinalysis shows elevated 24-hour methanephrin, and abdominal CT shows unilateral adrenal tumor. This patient has some of the classic features of a Theochromocytoma, and how you initially manage this is you need to give them phenoxybenzamine followed by propranolol. This is because you need to control their symptoms and their blood pressure before they have any surgery. So as I say, you don't want to give them adrenalectomy straight away because you need to control the symptoms. It's important, you want to give them propranolol at some stage because it will reduce their heart rate and reduce their panic attacks essentially. But you also don't want to give the propranolol before the phenoxybenzamine, as counterintuitively it can actually make the hypertension worse. So Theochromocytoma. What is it? So it's a catecholamine producing tumor, usually within the adrenal medulla, but it's more rarely from the extra-adrenal source. So there's the rules of 10 when thinking about the causes of this. So 10% are due to familial syndromes, like men, 10% are due to bilateral, and 10% are actually malignant, and a further 10% are usually found outside the adrenals, so in your sympathetic chains, that you're probably familiar with from your anatomy. So, presentation of Theochromocytoma. So, thinking about the presentations, so the symptoms are often episodic. They may have a classic triad of headache, sweating, and tachycardia. They may have abdominal pain, vomiting, diarrhea. They may have these episodes of anxiety where they become very flushed and have chest tightness and breathlessness as well. How do you investigate? Often have raised white cells. You want to measure their plasma and urine metanephrines. So these, usually most people say 3 samples of 24-hour urinary metanephrines and normetanephrines, but plasma metanephrines are sometimes measured, and you can do some imaging to localize the pheochromocytoma as well. So in terms of surgery for these patients, so that is the most definitive management, to remove the source of the excess catecholamine. You want to do give them the alpha blockade pre-op, and as I said before, you want to avoid giving a beta blocker before this, because if they have unopposed adrenal alpha adrenergic stimulation, this can cause their hypertensive crisis to become a lot worse. You want to beta block them after alpha blocking if they have ischemic heart disease or tachycardia. You don't want to precipitate an MI. And post-op, you want to be monitoring their blood pressure and monitoring their urinary metanephrines to make sure that it has resolved. So the main issues with pheochromocytomas are these acute hypertensive crises. So this can happen if you beta block before you alpha block, can be caused by stress, can be caused by a woman in labor, giving someone general anesthetic or contrast media, or even doing an abdominal exam and palpating an abdomen. So these patients are often very pyrexic, extremely hypertensive, have a very bad pulsing headache. They're often pale, and they often complain of a sense of impending doom. On the ECG, they may have a degree of ischemic changes as well. So how do you manage them? You want to give them IV short-acting alpha blockade, and then switch over to a long-acting oral alpha blockade once their BP is controlled, and then you manage as you would for a normal pheochromocytoma. So another question, 45-year-old woman presents to a GP with long-standing constipation and new onset back pain, mentions being thirsty regularly and passing large volumes of urine. Her blood show raised serum calcium, low serum phosphate, and a normal PTH. So the most likely diagnosis in this case is a parathyroid adenoma. So this patient has primary hyperparathyroidism, and you may think that, okay, she has a normal PTH, but this is inappropriately normal. So because she has a raised serum calcium, you'd expect her PTH to be suppressed through negative feedback, but the fact that it's normal suggests that there's a degree of secretion which is independent of calcium control. So moving on to talk about hypercalcemia. So how these patients present. So you may be familiar with bones, stones, moans, and groans. So bones, so they'll have bony pain and fractures because of resorptive bone disease. They're more prone to getting renal calculi, so they may get renal colicky pain. They often have psychiatric symptoms of depression and confusion, and they often have abdominal symptoms, so abdominal pain, constipation. They may get peptic ulcers and pancreatitis as well. Thinking about other features, they may have polyuria, polydipsia, weak, tired, and they may have some weight loss. When you're thinking about the signs that these patients have, they may be hypertensive, and they may have arrhythmias, and they may appear dehydrated or in shock if it's severe. Again, this is mainly due to their polydipsia. And if they've got erosive bone disease, then they may have bony tenderness. So how would you classify the causes of hypercalcemia? So first thing you have to ask yourself, is the PTH suppressed or is it not? So if it's not suppressed, so raised or inappropriate normal, then the most common cause is going to be primary hyperparathyroidism. A more rare cause is familial hypocalsteric hypercalcemia, and this is just that there's, due to a mutation in your calcium sensing receptor. It means that there's the threshold at which PTH secretion is acted on is changed. If the PTH is suppressed, then this is an appropriate response to hypercalcemia. So that means there's another source of this calcium. Most common cause in these patients is malignancy. Other causes, sarcoidosis, patients got excessive vitamin D, hypothyroidism as well. Okay, so primary hyperparathyroidism. So is the most common cause of hypercalcemia. Can be caused by an adenoma, hyperplasia of the gland, or carcinoma. Hyperplasia more associated with MEN1. More common in women, and you get the features as I said before. So raised calcium, low phosphate, inappropriately normal or raised PTH, and a raised urinary 24-hour calcium measurement. They will often have a raised ALP as well, because your PTH is acting on your bone and causing your bone to be resorbed. So that's why these patients often have the classical bones, stones, moans, and groans. Hypercalcia in malignancy can be from 3 sources. So it can be due to a PTH like peptide, which is acting on PTH receptors. So like in small cell lung carcinoma. Can be due to bony metastasis, so more common with breast cancer, or can be due to hematological malignancy, so myeloma, where the cytokines themselves are acting directly on the osteoclast to stimulate bone resorption. So I touched on these before. So other causes of PTH independent hypercalcemia, sarcoidosis, because you have increased 1-alpha hydroxylation of vitamin D, causing it to become active. Thyrotoxicosis, because you have increased bone turnover, hyperadrenalism, and for fact excess cortisol as well. Those are diuretics because they impair, they alter renal calcium transport, so you get increased calcium levels in the blood, and excessive vitamin D. So how do you investigate hypercalcemia? So you do a set of routine bloods. You may want to consider serum and urine electrophoresis, particularly if the patient's older and you may be concerned about myeloma. You want to do an ECG because they may have arrhythmias or a short QT. Short QT is the most common feature on ECG for a patient with hypercalcemia. You may want to do some x-rays of bones to see if they have any classical changes or signs of resorption. You may want to get a chest x-ray, again looking for any signs of malignancy. And they want to do a bone scan, again looking for any signs of local bone disease. How you manage hypercalcemia. Skip ahead a bit. How do you manage hypercalcemia? So these patients are often dehydrated, so you need to give them some saline to correct fluid deficit. If you think that they may be at risk of fluid overload, or they may need further fluid, you can give them some furosemide as well. And you want to carefully monitor their using calcium and fluid balance. If after IV saline, they're still not resolving, you can start some IV bisphosphonates in refractory hypercalcemic cases. And you want to ultimately treat the underlying cause. And you are actually giving quite a lot of IV saline, so usually you're giving 1 litre every 4 to 6 hours for 24 hours. So you're really rehydrating the patient. Primary hyperparathyroidism, if it's mild, then again, you just want to encourage increasing their fluid intake and reviewing them after 6 months. And if they are on any drugs which may be affecting their calcium levels like thiazide, you should avoid them. You may want to consider surgical excision of the gland. So main indications for this are symptomatic disease, younger patients, and if they have very high serum calcium. You often do a pre-op ultrasound and other imaging to localize adenoma, and intraoperatively you want to do PTH sampling to confirm you remove the actual gland that's responsible. Obviously, the complications similar to doing an operation for thyroidectomy, so hypothyroidism, hyperparathyroidism, afterwards a recurrent laryngeal nerve injury. If the hypercalcemia returns despite surgical intervention, or if they're not suitable for surgery, you can try a calcium mimetic like cinacalcet, which increases the sensitivity of the parathyroid to the calcium in circulation. So this is another scenario: lady with chronic kidney disease, low serum calcium, raised ALP, and raised BCH, a very tender proximal weakness. So she has classic features of secondary hyperparathyroidism. So she's got raised ALP, a low serum calcium, and this is likely due to a chronic kidney disease and the resulting vitamin D deficiency. So you want to replace this with vitamin D, and in this case you want to give her alpha-calcidol, and I'll talk about why later on. So hypocalcemia, thinking about the cause of hypocalcemia, again, you can divide it based on the PTH levels. If it's not PTH driven, then you've actually got a high PTH or normal PTH. The main cause is vitamin D deficiency. Can be due to chronic kidney disease because you've got reduced vitamin D activation, can be due to PTH resistance, and you can actually get hypercalcemia also in acute pancreatitis, and in alcoholic patients they can become hypocalcemic. If the PTH production is low by the thyroid gland, so hypoparathyroidism, can be due to surgery in the gland, an autoimmune response in the hypoparathyroid gland, congenital absence of the parathyroids, or magnesium deficiency because this affects PTH regulation. How does hypocalcemia present? So neuromuscular presentation is most common. So they may have spasms of the hands and the feet, twitching muscles, and perioral paresthesia. May have dry skin, coarse hair, and generally fatigued and low mood. The signs are usually more classic in questions for exams, so hyperreflexia, tetany, Trousseau signs. This is where you inflate a BP cup and they get a hand spasm. Chopstick sign, where you tap the facial nerve on the face and you get twitching of the face on that same side. They may have arrhythmias, bradycardia, low blood pressure, and they're prone to cataracts. So one major cause of hypocalcemia is osteomalacia. So you get low calcium and raised PTH. So what causes this? So most common cause, vitamin D deficiency, chronic kidney disease, as I said before, anticonvulsants like phenytoin, because they increase the breakdown of vitamin D, lack of sunlight, and liver disease, again, lack of activation of vitamin D, or vitamin D resistance. These patients present with bony pain and tenderness because of the increased bone resorption from PTH action, so they're prone to fractures. And these patients often have proximal myopathy. So when you do their bloods, you'll find low calcium phosphate with a raised ALP and PTH because of the increased bone turnover, with a low vitamin D. You may choose to biopsy some of these patients, though it's not usually necessary. And an X-ray is often done, which shows loss of cortical bone, and you may see these looser zones. So it's illustrated on this X-ray here, where you get these pseudo fractures, often perpendicular to the cortex of the bone, usually on the BIMA or the humeral necks. So how do you investigate for hypocalcemia? So you can do blood tests, as I said before, and ECG. Usually they have a prolonged QT and ST abnormalities. How do you manage hypocalcemia? Depends on the severity of the symptoms. If it's mild symptoms, then you can just give them all calcium vitamin D supplements. If it's severe, then you want to replace the calcium IV with 10 mils, 10% calcium gluconate. You also want to correct any underlying magnesium deficiency as well. If they're asymptomatic and it's a mild degree of hypocalcemia, you can actually just monitor them. Osteomalacia, more specific management, give them calcium vitamin D supplements, but which vitamin D supplements you give depends on the underlying cause. If it's due to malabsorption or hepatic disease, you want to give them ergocalciferol, which is vitamin D2, or parenteral calcitriol to overcome the malabsorption and the lack of activation in the liver. If it's renal disease or vitamin D resistance, then you want to give them alpha-calcitor or calcitriol, which is already fully activated vitamin D and doesn't require any further activation. Just another question. So, 52-year-old woman on the respiratory ward currently being treated for a community-acquired pneumonia. Daily blood shows sodium levels 128, clinically euvolemic, thyroid function is normal, Short's and Acton test shows no abnormality. So this patient has what appears to be euvolemic hyponatremia. So the management for this would be initially fluid restriction. So hyponatremia is a sodium of less than 135. Usually will be picked up incidentally. It can present non-specifically, like nausea, anorexia, malaise. In more severe states, they may have neurological features, so confusion, weakness, irritability, and hyperreflexia. If it's very severe, so having a sodium less than 120, they may have reduced UCS and seizures. So determining the cause of hyponatremia depends on the clinical assessment. So are they hypovolemic, euvolemic, or hypervolemic? The hypovolemic causes are diarrhea, vomiting, diuretics, or salt-losing nephropathies. Hypervolemia, nephrotic syndrome, renal failure, hepatic cirrhosis, and heart failure. And euvolemic causes hypothyroidism, adrenal insufficiency, just someone having too much fluid or excess 5% glucose infusions, or SIADH. And remember that SIADH is a diagnosis of exclusion once the other causes have been ruled out. So assessing fluid status is key to determining the cause. So features that may indicate hypovolemia are tachycardia, postural hypertension, dry mucous membranes, diffuse skin turgor, confusion, and reduced urine output. Hypervolemic, you want to look at the JVP, see if it's raised. You want to see if there's any bibasal crepitations and if they have any evidence of pitching bilateral edema in the peripheries. Investigating hyponatremia, so a set of routine bloods is always useful. Getting some plasma osmolality and the paired urine osmolality. and you want to do TFTs and short synaptin test in a patient who is euvolemic to make sure that adrenal insufficiency and hyperthyroidism are not the cause. Urine osmolality is useful, and urine sodium in particular, because it can give you a clue to diagnosis. So if urine sodium is more than 20 and the patient is hypovolemic, then it's usually due to a renal cause. If it's less than 20 and the patient's hypovolemic, then it's due to a non-renal loss of fluid. So how do you manage a patient with hyponatremia? So the important thing is aiming for no more than a rise in 10 millimoles per litre per day because of the risk of osmotic demyelination if it happens any quicker, and this can be potentially severe, resulting in quadriplegia, seizures, and death. So if they're hypovolemic, you just want to replace the volume with 0.9% saline. If they're hypervolemic, you want to fluid restrict the patient and treat the underlying cause. And similarly with euvolemic patients, you want to fluid restrict and again treat the underlying cause. If they have severe hyponatremia, then it's important you seek expert help. So usually this would be from Endocrine in most hospitals, and they'd often recommend giving the hypertonic saline. This can be done on a ward setting, but in most cases it will be done in a HDU setting at the very least. SEIDH, just to touch on, as says, diagnosis of exclusion. So they must be euvolemic, not hypothyroid or have any adrenal insufficiency, have a urine sodium of more than 20, have a reduced plasma osmolality and an increased urine osmolality. So basically they have quite dilute plasma but quite concentrated urine, essentially what that's saying. And SAIDH causes broadly can be categorized as any CNS disease, any lung disease, underlying tumors, recent surgery, or drugs. And the most common culprits are antidepressants, SSRIs, and tricyclics, opiates, PPIs, and carbamazepine. So it's always worth referring to drug charts and seeing if the patients are on any of these, if the patient is hyponatremic. And managing SRIDH, as I said before, fluid restriction, usually 1 litre a day initially. If fluid restriction is not working, you can escalate further fluid restriction. And if that fails, then you may want to consider ADH antagonists, so dimethylcycline or tolvaptan. But it's important if the patient's on any of these drugs that they actually are not fluid restricted, because they may become profoundly dehydrated otherwise. And that's because, sorry, I should have said that these drugs are ADH, because they're ADH antagonists, they will cause you to actually lose fluid. And another question, 82-year-old man admitted with acute diverticulitis, which isn't settled. Daily blood sugar sodium is 152. Poor skin turgor, dry mucous membranes, and blood pressure is 105/78. Urine and serum osmolality is both raised. So this patient is hyponatremic, and they're also dehydrated. So I'll come on to why this answer is what it is, but you'd give them a litre of saline of over 6 hours to correct their dehydration and their hyponatremia. So hyponatremia is sodium more than 145 in most labs, and like with hyponatremia, it's usually picked up incidentally and can also present non-specifically. So what causes it? So most cases, unreplaced water losses. So from the GI tract, from sweating, or so if someone's got pyrexia, burns, renal losses. So someone with poorly controlled diabetes may have glycosuria and which acts osmotically and causes them to lose fluid. Osmotic diuresis or reduced ADH release or action, such as in diabetes insipidus. Inadequate intake is something to consider, especially in patients who are elderly. or if they have hypothalamic disease because they may lose their thirst control. Rarely it can be due to excess true sodium, so iatrogenic or Con syndrome. But an important thing to remember with hyponatremia is it's usually a fluid problem rather than a sodium problem. So how do you investigate? You want to rule out other causes. So serum glucose, make sure they're not diabetic, serum potassium, and serum calcium, because these can cause nephrogenic diabetes insipidus. And you want your plasma and urine osmolalities as you would for hyponatremia. And further investigations would depend on what your suspected cause is. So if you suspect diabetes insipidus, you'd want to do a water deprivation test. You'd want to do a CT or MRI head if you suspect there's a cranial cause of BI, and you'd want to review medications to make sure they're not on anything like lithium or dimethylocycline, which can cause nephrogenic diabetes insipidus. How do you manage hyponatremia? You want to slowly correct their sodium. Again, no more than 10 millimoles per litre in the day. If they're hypovolemic, you give them 0.9% saline until they're normovolemic, usually 1 litre every 6 hours. And while this is quite counterintuitive, it's important to remember that 0.9% saline is actually relatively hypotonic compared to the patient's plasma when they're hyponatremic. And it will help also to prevent any sudden shifts in sodium. If the patient's normovolemic, then you want to either encourage oral fluids, or if they're not having oral intake, then you can give them 5% dextrose or glucose 1 litre every 6 hours. Again, monitoring their fluid balance and plasma sodium levels.